And the reason why we considered ranolazine in this case was because ranolazine has an effect on HbA1c, positive effect. It has been shown to be useful in microvascular angina, and we know that microvascular angina is quite prevalent in people with angina despite a successful angioplasty. We know that ranolazine is also a good agent in obstructive coronary artery disease, which can be combined with calcium channel blockers and beta blockers. So, in a way, it solves our problem to use a drug like ranolazine. What is the evidence we have to use it? This slide shows a meta-analysis carried out by Luigi Savarese, which analyzed the large studies that have been carried out using ranolazine, and he showed that ranolazine with placebo increased exercise time and reduced both weekly angina and the to use GTN, so the anti-angina effect. Beasley and colleagues a few years ago made a comparison between different agents, and they concluded that beta blockers and blockers are confirmed effective anti-anginals. Ranolazine used with the blocker or calcium blocker showed benefits across all the outcomes assessed, whereas long-acting and trimazidine were positive only in certain subgroups of individuals, not across the whole spectrum. And ivabradine, which in another case, has relatively inconsistent effect in the different categories tested. Very important. This study, the Teresa study, which was a trial focused on the use of ranolazine in people with chronic stable angina, and showed a very important positive effect on weak angina pain and the use of GTN. So these patients improved over time with the use of ranolazine. So again, another evidence that it is a good anti-anginal, and it's a good anti-anginal in patients with diabetes. And the Teresa study confirmed previous data from Chaitman and colleagues who showed that in patients with diabetes, shown here in the yellow bars, ranolazine had a very important effect on angina and use of GTN, or nitrous or GTN to treat the angina. And the other observation in this study by Chaitman was that the use of ranolazine was associated with an improvement in HbA1c levels. And that was a very interesting observation. And it was an observation that was later confirmed by other studies, which actually highlighted the fact that ranolazine at this level, at the level of glucagon secretion, acting on the isol alpha cell, and that's improving hyperglycemia. And I'll come back to this in the next slide. So once this effect was observed in relatively smaller studies, it was tested in a larger group of patients. So the Merlin TIMI 36 was a very large randomized control study, looked at the association between the use of ranolazine and the reduction in HbA1c levels in patients with diabetes and in patients without diabetes. And it is quite interesting, the fact that this study, which was a large study, showed that ranolazine significantly lowered HbA1c in patients with established coronary artery disease and diabetes, and reduced the potential increase in HbA1c in individuals without evidence of previous hyperglycemia. So a very clear effect on the metabolic component of these patients. And this slide shows graphically, compared to placebo, the good effect of ranolazine on HbA1c levels in patients with diabetes, and the lack of increase of HbA1c in individuals without diabetes compared with placebo. So we have a drug that actually is effective in ischemia and is effective in diabetes. And the fact that this is effective in ischemia has been shown again in the study, showing that the risk of recurrent ischemia at 1 year is reduced who received ranolazine compared with those on placebo. Very importantly, and I want to highlight that hypoglycemia did not occur in patients treated with ranolazine in this study. And this is important. I see you before about the measurements of hypoglycemia in terms of prognosis. And more recently, and this is more contemporaneous, if you wish, type of patient, this study by Robert Eckel and colleagues in 2015 showed the effect of ranolazine on HbA1c compared with placebo, confirming the effect that I mentioned to you previously. And I have no time to discuss this in detail, but what we know now is that ranolazine inhibits glucagon secretion from pancreatic alpha cells by inhibiting the electrical activity of these cells by blocking the sodium channels, which is the effect of ranolazine, which has been confirmed. So this actually shows that this agent management of ischemic heart disease, both the obstructive forms and the dynamic forms, such as microvascular dysfunction. And when you consider the fact that the majority of the anti-anginal agents we use nowadays do not have an effect, a positive effect on the diabetic status of the patient, and on the contrary, some kind of things worse, and the having a medication that allows us to treat patients with diabetes, knowing that we can lower the glucose levels and the HbA1c without causing hypoglycemia, is quite an important finding. And this confirms what has been sort of suggested some time ago, that these kind of agents can benefit a number of patient subgroups. And it is very important that we cardiologists try to identify what kind of patient we're dealing with by paying a lot of attention to the symptoms, the presentation, the potential pathophysiology, and the risk factors of these individuals, because we know that these drugs like ranolazine can be useful in a large variety of conditions, particularly in this patient with diabetes. I will summarize the 6-month follow-up visit of this patient. What I think the major change in terms of her symptoms was that she did not experience any more episodes of angina at rest. And I think this is because of the use of the amlodipine and the ranolazine. Her exercise capacity improved, so she can go upstairs now at home. She can go shopping, and is not getting the chest tightness that she used to get on exercising. I think that this is the effect of both the proper sort of management of her risk factors, her obesity, and the use of a drug like ranolazine, which actually improved the coronary microvascular dysfunction. So the next follow-up of this patient will include a repeat stress echo and a repeat cardiac MRI perfusion scan to see whether we have improved the contractility of the ventricle on exercise, and if we have actually managed to improve the microvascular dysfunction that we saw with the cardiac MRI previously. So let's think about the pathogenesis of angina in our patients. How can we modify the risk factors, and which agents can we use that we do not usually consider first line, but can be first line in individuals who specifically may benefit from the mechanism of action of this